So basically, on the 25th of March, all NHS dental practices across the country were written to, basically telling them the immediate changes that needed to be made in order to limit the transmission of COVID-19. So what this in effect meant that all routine, non-urgent dental care, including orthodontics, were to be deferred, and all practices were instructed to effectively establish a remote urgent care service providing telephone advice, triage for patients, and then those with urgent needs were directed to a network of urgent dental care hubs, which we as a region had established for those who were in urgent need and needed face-to-face care where that was deemed clinically necessary. So in effect, in a nutshell, what that meant was all dentistry was stood down, all routine dentistry was stood down. And effectively what it meant was practices were effectively closed to any form of walk-in type of work, and were only really working at from a remote position of taking telephone calls from patients, because that was the limit of what they were actually allowed to do. In terms of what that meant for patients was that any of those in urgent need were initially advised, obviously, speak to their practice. They were then, if it was deemed by the dentist talking to them that they needed urgent care, they were referred on to what we have in London known as the dental nurse triage service. Now, this normally operates just evenings and at weekends and bank holidays, but because of the fact that dental practices were closed, this was turned over to a 24/7 operation. So the call handlers, which are all nurses, were then working during the daytime as well. The call would go through to them. They would then effectively talk to the patient, ascertain the situation, and if required, would then refer them on to one of the urgent dental care centres that we had set up across London. Now, what it's worth saying that the urgent dental care centres were a combination of some of our acute hospital providers, some of our community dental services, but also we also had some primary care based practices as well. And the combination of these meant that probably by the beginning of May, we had 41 of these centres across London. And just to give you an overview, the acute hospitals that turned over some of their operation to urgent care were Guy's Hospital, King's, UCLH, St George's, Kingston, and Barts. The CDSs were effectively Whittington, CLCH, Kent Community, and Bromley. And then we had 13 practices spread out across London that were delivering these services. Now, what these meant was these services were working anywhere from 8 in the morning, and some, because they already exist as out-of-hours providers, would work through to 1 a.m. in the morning, if need be, because that's part of their contract. So this went on for some while. So the only face-to-face dentistry being delivered was effectively through these urgent dental care centres. Across London, we had them spread. North East had 1.8 sites, and they were spread out, a relatively similar size patch. 9 sites in Northwest, 11 in Southeast, and a lot of it's dependent on the facilities that exist, but also in the cases of the urgent dental care centres, was that they the minimum was that they all had to have the adequate PPE in place, which is the personal protective equipment. Now, for dentists, this includes a face mask, not a normal surgical mask, but a face mask that has to be fitted properly to enable them to deliver what they call AGPs, which is a technical term for anything where a drill is required, because it generates an aerosol, and therefore the dentist and the dental staff have to have these masks on which prevent any of the droplets getting into either their nose or their mouth. And also they have to wear a full-length gown as well. So that's why anyone going into a dental practice at the moment will probably be a little bit surprised, because obviously in some cases it's quite hard to understand what the dentist is saying to you because they've got this mask on their face. But it is a requirement for them to do that. So we were working in this way pretty much from the end of March all the way through till early June. At which case, obviously, things nationally were starting to change in terms of the transmission of COVID, and on the 28th of May, a sort of, well, it was an announcement that was made actually on the TV by the Prime Minister, was that all dental practices could recommence opening from the 8th of June for all face-to-face care. So what that meant was, obviously, assuming they were in a position where they had the relevant PPE in place and they were able to deliver services, they could, from Monday the 8th of June, open. And what's happened since then, in a staged way, all practices have reopened and are reopening. And by Monday, effectively the 5th of October, all practices are expected to be stood up and delivering the full range of services to patients. There may be some exceptions to that, where either a dental practice has members of staff who have health conditions, which mean that doing that may well be not possible at the moment, or it could be just the logistics of the practice don't allow them to either maintain sufficient social distancing, or it may well be the airflow in the practice is just not good enough in order to remove the aerosol from the room. And so what's happened, although practices are stood up and working again, their capacity to see the volume of patients they would have done pre-COVID is severely reduced, because after any procedure, they have to leave the room for a fallow period of up to an hour. It depends on the airflow system in a practice, but obviously if you're having to leave a treatment room for an hour before it can be cleaned, that's a significant period of time where patients can't be seen. So it has been a difficult process, and practices are slowly getting back to some form of normal delivery, but their ability to see the numbers of patients they would have seen previously they're still not there. And therefore, what we have done is that the urgent dental care centres that we had commissioned, we have maintained that operation in London, because there are a significant group of patients who don't have a dentist anyway and need to be seen, but also there are a number of patients who are not able to be seen in a timely manner at their own practice, and if it's an urgent situation, those patients still need to be seen. So we have a considerable number of urgent dental care providers across London, primary care now, who patients can be referred to if they have an urgent problem. In terms of the normal resumption routine stuff, it will differ from practice to practice in terms of what their capacity is. Some are in a more advantageous position than others, purely because of the size of the practice or the number of dentists they actually have working in them. And in terms of primary care, that's obviously your high street dentists. The resumption of normal service delivery by our acute hospitals and community dental services, that has resumed, but again they are working in quite a constrained environment, because again they have to follow the same rules in terms of ensuring that they have the adequate PPE, and also the same process applies to them in terms of any of the aerosol generating procedures that they undertake on a patient. The rooms have to be left for a level of fallow time in order for the aerosol to dissipate before they can go into the room and clean it. So what I think I'll do is I will leave it there, just that gives you a potted version of where we are. I suppose the summary is general dentistry is stood back up again, and has been in a staggered way since the 8th of June. But in terms of the capacity to deliver at previous levels, we're not there yet. So I think I would leave it at that, unless any, and so obviously if people have got questions to ask, then please do. Yes, happy to take any questions on the back of that.
Thank you very much, Jeremy. Any specific questions for what Jeremy was talking until now? Yes, Malcolm? Oh, we can't hear you. Okay, let me. So I'm asking you to unmute yourself. Not yet, no.
Canary, it's probably unmute the M
I
symbol, because that's the one that's probably Malcolm speaks through.
yeah, that's what I did for both of them.
All right, okay. Malcolm?
But, Malcolm, are you receiving the message there? Or if it's easier, you can type it in the chat box.
Whilst Malcolm's trying to figure that out, I'll follow up for problem control. Thank you, Jeremy. That was very helpful. I can see it's quite a challenging situation. It's good to hear that the dentists are opening up next week, although, as you say, reduced capacity. I'm just thinking about about children at the moment. We know that there's been some reports in the press probably seen about dentists worrying about children's tooth decay and over this period. Is there any kind of creative ways that dentists could deal with this in terms of going into schools or something like that to actually allow them to kind of? Because I see a volume issue sort of thing. How do you get people through? But is there a way? There is a volume. Into that?
I mean, I think in practical terms, yes, they can. But the issue is, as it is for any organisation at the moment, it's this issue around the safety aspect of actually a group of people coming into the school to effectively undertake some form of oral assessment. And so the schools are quite constrained as well at the moment in terms of what they can and can't do. But yes, so in effect, there is a possibility there. And obviously our community dental services obviously look after, paediatric dentistry is a big part of what they deliver. And so I think this is really building on some of the stuff that we're going to be doing anyway in terms of an oral health campaign, which is supervised toothbrushing and all the rest of it. However, obviously in order to do that, they need to be able to access the children to do that. And that is the limiting factor at the moment, because obviously people coming in services is one thing, but them going out into various venues to do this is fraught with the logistical start of that. The size of that is quite, and also the services themselves, obviously, because they are working through a backlog, and most of what gets done around paediatrics is our community dental services. They are obviously working through a backlog associated with both paediatrics and special care within the various sites that they work from, and obviously any delivery that gets done off-site removes people away from the front line at the clinics themselves. So it is a real balancing act for them to sort of try and manage, really.
Yeah, I can see that. It sounds an extremely challenging logistical issue, isn't it? And it's kind of, I mean, locally, how could we kind of encourage local work to kind of support this at all? I mean, it's kind of, because I mean that's partly what our role is, to kind of make sure that hopefully things work better for people, particularly this time. So. Yeah,
I mean, I think that the first and foremost really is that the and I think what's happened is since the 8th of June, practices. I mean, it's not like the majority of practices are stood up and are working now. The 5th of October was the deadline that we gave everyone, because the reason we did that was because all practices have to undergo a level of fit test training now because of the respirators that they have to wear. That takes time. We've managed to do that in London, which has been great. And also obviously ensuring that they've got the PPE, but also any sort of structural changes that they might need to make within the practice in order to make, whether it's a one-way system that they've instigated or something like that, that give them the time to actually undertake and maybe change the way they work. I mean, there's all sorts of stuff going on depending on the size of the practice. If you've got like a 3-chair room, one for the hygienist, you've got a situation where some practices are working like a double shift. So, you know, you'll have this dentist working in the morning, which means that if he does an AGP in this room, he can then go across to the other room while that one row's fallow. And then what happens is the other dentist, there's all sorts. So they are being quite sort of innovative, because they have to. Otherwise, the volume of patients just builds, and they're just not being able to get through it. So yeah, so we are getting there. But I think the new normal for general dentistry is considerably different to what it was pre-COVID.
And it's, I mean, in terms of the kind of the general issue, it's kind of, I mean, I'm sure you probably are doing this, but just to understand how you're doing it, it's kind of
Sure, yeah.
telling people about what's actually happening and how you engage with the dentist. I mean, Healthwatch England will be very interested, I think, to actually kind of promote this across our network, to actually make sure that we're actually telling people about this, because it's been a big issue for Healthwatch England.
Sure, yeah, I know, and I think the longer it went on, I think just to give a bit of context, I mean, in London we were about 2 weeks ahead of everyone else in terms of establishing the urgent dental centres, because we could see very quickly what was going to happen, and once we'd got early wind of what was going to happen in terms of dentistry being closed down, and what it did is it meant that we avoided a bottleneck of patients who were waiting. And it meant that actually, if you were in urgent need, you would generally get seen within 24 hours of making that phone call, which for the majority of the country wasn't the case. But I think, again, because of the size of the population we've got in London, you know, we can't afford to be in a position where we wait. We had to instigate that. I think in terms of communication, yeah, I mean, there's obviously some national messaging going out. And what we've been keen to do is we've made sure that the STPs, who are effectively the new commissioning for everything that's not dentistry, made sure that they're aware. So we've been monthly giving them a regular update in terms of the status of practices in their area, so that we know, or they know, that actually this number of practices are delivering the full range of services. There may be a few that aren't, but we're in that situation at the moment. So I think it's there is a level of communication. Quite a lot of it is national messaging, and I think it's just been complicated a little bit, because obviously now we're entering into a cycle of local lockdowns, which actually but I mean, thankfully in London, what we're working on is that even if there is a scenario where a more stringent lockdown, is that we're of the view that dentistry won't have to stop next time round. It will carry on, because they have all of the safeguards in place, which works on the basis that everyone coming through the door is a COVID patient and that they're protected. So I think, to give you a level of reassurance, I mean, obviously the only thing that could override that is if the chief dental officer says it's all going to stop again. But I think the general view is that that won't happen.
Okay, thank you. I have to go to another meeting now, but thank you very much. Appreciate that.
Thanks, John, for the questions.
No, you're welcome.
Thanks, Jeremy, for all the useful information. That was really, really useful. So looking forward to 5th of October and see how everything will be operating then, and what access patients will actually have. Because currently we and volunteers are working on getting some information from dentist services in Hackney to see what kind of services they're currently providing, how easy it is for a new patient to register if they want.
Yeah, I mean that's the issue. I mean, I think what we're working on is, so I think that those patients who don't have a dentist and are trying to get one, that is a difficult one at the moment, because obviously what the practice is saying, look, we've got a backlog of this. To get through our own patients or our current patients is a difficult. But that's why we've kept the urgent dental care hubs running. So it means that if you are in urgent need, I think if people are saying, look, I just want to sign up with a dentist, that can be a bit difficult. I think if someone gets in acute pain, they will be dealt with. No one's going to be left waiting or in acute pain. They can be dealt with. And because we're mindful that most practices, even if they're back up and running now, their ability to see loads and loads of patients is severely compromised at the moment. And they will have days and days of weeks and weeks of treatment booked up, because they may well only be able to see half the number of patients they previously would.
Yes, and another thing with new registered patients is that some practices said that their NHS list is already full, so they're not accepting new NHS patients.
Yeah, it's a bit of a misnomer in a way. I mean, I think just to give it, because effectively is NHS registration with dentists formally doesn't exist. So patients, you know, can sign up with a dentist, but basically it's all about their capacity. So that's why we're trying to keep the urgent dental care available. It will get better, and it will improve. It's just that this is all part of the recovery of services. And so some practices will be fine. They'll be able to see new patients, or they might say, look, we can take you on, but we won't be able to see you for 6 months. But obviously, if you've got no issues, then that's fine. If they have got a problem, there is an outlet for them.
Yeah, no, we've done some mystery shopping, and we've probably called around 35 dental practices in Hackney. And overall, we've obviously pretended that we have shattered tooth and we were not in pain, but we were asking what if we are in pain and we're not registered with you. So most of them said, just give us a call and we'll give you some antibiotics or, you know, any pain relief, which was really, really good. Disorder, Jeremy, where is the dental hub for Hackney?
So you've got, what I'll do is I'll send them to you. So they're all primary care based. So just so people are aware, so I'll send you the details of those. We've got quite a number there. North East London was always, you know, going to be an area where the demand was high, because there are a high, you know, and I'm not just about Hackney, but certainly in Newham and Tower Hamlets and places like that, there are lots and lots of people who do not go to the dentist regularly. And so obviously, you know, people get toothache, you know, regardless of a pandemic, you know, people do get toothache and it needs to be dealt with. So, but what we did have is St Leonard's, obviously, is normally a community dental services provider, but they actually turned over their operation there, or part of their operations, so that they were a hub. And so people were going there just to have urgent dental care sorted out. But obviously, once they then started to then resume their normal service delivery, their hubs were stood down, and then we replaced them with general practice type ones. But what I'll do, is I'll send you the full rundown of the hubs that exist. But just to say that how it works is it's not a direct referral in. What happens is it's the same process. Patient rings 111, they get put through to the triage, they're then triaged, and if it's assessed that they need to be treated, they are then actually referred directly to the whichever hub is closest to wherever the patient lives. So it's done that way, in a way to make sure that patients are genuinely in need. And part of it is also, even with the dentists, if you go through to a dentist, their threshold for saying, oh, well, we better take a look, is much lower. And actually, in a lot of cases, a lot of it's antibiotics, as you were talking about. It doesn't necessarily require a face-to-face consultation. So it's that. But I'll send you the details of the hubs, and then you can circulate them to the members.
Thank you. So I guess the St Leonard's hub was put together much later on after the lockdown, because in the very beginning there were no hubs in Hackney. They were all outside of the borough, right?
Yeah, so initially, so Hackney came on a bit later, but I think pretty much from about May time we had something. Yeah, I think the thing is with St Leonard's as well, obviously, you know, their operation is quite small in terms of the numbers of patients they could see. So, and then we had obviously a number of other hubs in and around the neighbouring boroughs. But it's not something that we could actually, I mean, most of it was generated on the basis of either existing providers saying, yes, we'll do it, or other primary care providers actually saying, we would quite like to be a hub. So, you know, we had one down in Tower Hamlets quite early on. So, you know, because it is urgent dental care, there is an expectation to an extent that people may have to travel a little bit.
Right. Yeah. And just very last thing on this. So we've been talking to many of our members, and you know, there is a big concern that a second lockdown may come. So if this happens, in case, hopefully not, will there be another hub in Hackney, or that people have to travel outside of the borough again?
No. Even if the feeling is at the moment that even if there is another lockdown, the general dental practices won't close.
Okay.
Like they did last time. So we're because of the various measures that are in place, which mean that they are safe, they can safely deliver dentistry, even if the patient happens to be COVID positive. So that, whereas before they didn't have the proper PPE in place, they didn't have the various measures in place to make the practice safe, they have all of that now. So if there is another, you know, for want of a repeat of what happened last time, the general feeling is that dentistry won't close.
Right. Okay, that's the reassurance.
Yeah.
Okay. Right. Malcolm, we can hear you now.
Can you hear me now?
Yes, we can.
You can hear me. Okay.
Yeah.
Thank you very much. Okay. I was rather interested that in my dentist, that it's an urgent dental care centre.
Yeah.
But it's not doing ordinary NHS work, it's only doing private work, apart from being an urgent dental care centre. And I just wonder how this is tolerable for the practice to take on that important NHS duty and then exclude all other patients.
I mean, I don't know which one you're referring to, but in most cases they will have stood up. So it won't be a situation going forward that they would only be doing it depends on the basis of their contract. I don't know, without knowing the detail of one. We've got a number.
Okay. I'll send you the information, but it's got a sign on the door saying no NHS patients apart from urgent dental care centre. Yeah, so there are a couple of practices that have a predominantly small NHS contract. Actually, is it in Hackney itself? No, it's actually not in Hackney. No, I'll send you the details.
If you can, yeah. I mean, there may be a scenario where, because they actually had a very small NHS contract anyway, but also stood up as an urgent dental care hub, that they obviously would accept any patients referred as part of the urgent dental care. But actually, their normal contract wasn't much of an NHS contract anyway. And obviously, you know that there is a real mixed bag of NHS. The size of NHS dentist contracts across London anyway. But yeah, if you can send me the details, I can at least clarify it for you.
Yeah. Thank you.
Right, and we have one question. Will normal measures to save teeth will be offered and no just extractions?
Say again, sorry, I missed that, Canary.
So the question is, will normal measures to save teeth will be offered and not just extractions?
Yeah, that's right.
This is after the 5th of October.
Yeah, absolutely. I mean, you know, as I said, I mean, even now, you know, if a practice is full upstanding, the issue around the 5th of October is that's just the deadline by which we wouldn't expect anyone to be delivering any less than the full range of services. The vast majority of practices are stood up now anyway. But in terms of, you know, the issue around the tooth being saved is a clinical conversation. Now, obviously, during the pandemic, if a tooth was saved, well, they might have done it. But obviously, if a patient's in acute pain, obviously extraction is the one way to alleviate that pain. And there may well have been a level of more extraction than there might have otherwise been in normal circumstances. But as a matter of course, yeah, I mean, there would be a full assessment as to whether that tooth's savable or not.
Right. Thank you very much. If there are no more questions for Jeremy in this, we can move to the practical side of using dentistry services, if that's okay. And we have few questions from public that we've already received. Shall I continue? Any more questions for Jeremy now? No? Okay. So Jeremy, I sent you the questions in advance, but let me just briefly tell the attendees what is it about. So we've received questions from a resident in Hackney who was having recurring issues with bun filling and was advised that he needs root canal surgery. But he was offered this to be done privately only, as the practice he was registered with cannot do it on the NHS as an NHS patient. And the question from the resident is, and obviously you're welcome to share your own experiences as well and ask questions regarding that. So is it acceptable for my original NHS dentist to refuse to do the treatment on the NHS but offer it privately? If not, are there any penalties for that sort of behaviour?
So the technical aspect of that is they should never say to a patient, I'll only do it privately. If they're an NHS contractor, they should always do it. Now, in terms of the assessment of the particular, because the root canal treatment is a real issue. It has been ever since this contract was introduced back in 2006, on the basis that the general dentists feel that it's not remunerated adequately under this current contract, and therefore there's been probably less of it done under the NHS. Now, we've recognised this. There is a skill issue as well, because obviously in order to do root canal treatment, you do need to be sufficiently skilled at doing that. And there is an issue with a lot of dentists, particularly younger ones coming through, just don't have that skill or competency to do it. Another thing is around root canal treatment is it's one treatment that you need to get it right, because if you don't remove the infection in the tooth and then you end up sealing it in, that is considerably painful for a patient, and therefore if it's going to be done, it needs to be done properly. So I think that rather than get into the whole, technically no practice should ever say to a patient, I'm not doing it under the NHS, but I'll do it for you privately, because actually that's a breach of their contract. And if we get evidence of that, then obviously there are contractual sanctions that we can take. However, in London now, because what was happening was a lot of practices were then referring patients to hospital. Well, hospital is not the appropriate place to have what you would call routine dentistry delivered. It's a very expensive way of doing it. And also the threshold for what they call restorative dentistry in hospital is very high. So a lot of this treatment would not be delivered in hospital and would be rejected quite appropriately. But what we have in London now, we've had it since last year, is an intermediate level of provision across London for providers who just do endodontics, which is effectively root canal treatment. So what can happen is they are effectively referred into hospital. Hospital says, no, not sufficient for us. But rather than sending it back to the dentist and saying, back to you, you'll have to sort it out, they can refer it on to one of these tier 2 intermediate providers, and the patient will be treated. Now, the only thing I will say about that is not every tooth is savable. And I think it has to be a clinical judgment. If it's deemed that the tooth is stable enough for root canal treatment, that will be given. But in some cases, some people's teeth are not savable and are not stable enough for root canal treatment. And unfortunately, the only option there is to extract. And I think, but again, it's a clinical decision around how savable a tooth is. But we do have an outlet now for this type of case. So again, in terms of, I'm obviously not aware of the actual specifics, but if the patient needs a root canal treatment, they can be referred into hospital, and the hospital now will send them on to a tier 2 provider, assuming the tooth is savable in their opinion. And it will be done under the NHS, and the patient pays no more than they would normally do if it was going to be undertaken in practice.
Because this very patient was apparently referred to the UCLH, and the referral was rejected 3 times without any meaningful reason. And then he was transferred to secondary care. Yeah,
so basically what happens is if it goes into a queue, unless it's a very, very complex state of need, it won't be done in hospital. Hospitals will just reject those referrals out of hand because they are not commissioned to deliver routine dentistry. They are delivered, what you are referring to specialist a centre, i.e. hospital, and hospitals are not commissioned to deliver just normal, what you would call normal root canal surgery. That is the domain of either general dentistry or at the very least intermediate level services. Hospitals are not there to deliver routine dentistry.
Right. Thank you very much for that. I hope that was clear. Yes.
Yeah. So sorry. Hi, Jeremy. That was me that asked the question. Thank you for answering that so clearly. And it sounds like it makes sense around the hospital and the tier 2 provider, which is the situation I'm in now, being referred to the secondary care. The frustration lies around the first dentist that unashamedly is happy to do this privately, but not on the NHS. So what that means in practice is I spent a long time when I moved into the area finding a practice with good reviews, good feedback, and that's why I ended up with that one, and I've had good service there up until now. Now it's kind of gone around this loop, and the secondary care provider, hopefully they're good, but I wouldn't have chosen that practice in the first place because of the kind of poor reviews and feedback. So it's just kind of a frustrating circle, really.
No, I completely understand. I mean, I think the thing is, the reason why we've established an intermediate level delivery in London, no one else is doing this, by the way. We sort of stuck our neck out here and said, look, patients are not getting the care that they should be getting, and we can't. The thing is, it's this sort of push-pull scenario where you can say, well, dentists should do this. They're not doing it for all sorts of reasons. So we just thought, well, actually, it'd be better if we actually commissioned a level of service that sits between general practice and hospital. And I think the thing to say about these, regardless of, because these services, where they're cited, regardless of the reviews that are on there, these services are being delivered by specialists. So the people delivering the service will be either on the specialist list for endodontics or will be accredited as such. So what that says is that the treatment that you get there will be absolutely a standard that it should be, which is the most important thing. And it doesn't stop you staying with your current practice. Nothing compels you to, you might have the work done at this new provider, but it doesn't compel you to stay there. But as I said, it is a level of service that we could see straight away, and it has been for some time. So we were on it, and you can imagine it. There was a lot of pushback from certain quarters about us doing this, because obviously it is a little bit of hostage to fortune if you don't have something like this, because people are then put in the invidious position thinking, well, I want to get it done, I don't want to lose the tooth, and then end up paying privately, which is not right.
Yeah, and like you say, even though it's it's not the ideal situation, it's not what should be happening. The correct thing isn't happening, so you found this a solution which makes absolute sense. In terms of kind of aftercare provision, I assume the centre doing the root canal.
There'll be follow up there. Mm-hmm. Yeah, absolutely. And then what they would do is they would refer you back ultimately once, assuming everything's settled down. Because anyone who's had a root canal treatment will know it's not the most pleasant experience in the world. But there is, yes, they as part of the commissioned contract that they have, is they are obviously responsible to ensure that any residual issues that exist afterwards have to be remedied before you're referred back to your own dentist.
Great. One final question. I don't know kind of how clinical you are. Just in terms of everything that I've read, and that the dentist that wanted to charge me privately told me about root canal, described it as kind of normally a multi-stage process where at least the final stage of capping the tooth with a permanent filling would be done in a second follow-up appointment. Now, the secondary care centre were very adamant on the phone that they would be doing everything, come what may, in a single appointment, 2 hours.
It depends, and again, and this is what I say, because you're going into a specialist level of delivery, because they are endodontists, they have the relevant skill and expertise to be able to do it and what it does, what I can tell you though, is if there is a need for another appointment, then that exists as well, and as I said, there's no additional cost to patients on this basis, so it will be delivered. I think the thing is with root canal treatment, it does take a long time, and that is at the nub of all of this, that in terms of what the dentist gets via the NHS contract, they get the same level of contract currency that they would for a very quick extraction. There's nothing in it. So you can understand why they say, well, actually this, time, there's a lot of time. And, and it is quite a very intricate procedure. Hence, the time does need to be taken. I think also the capping of it at the end, a lot of people who end up with root canal treatment end up with a crown. Not always, but quite often they do end up with a crown on, because obviously the tooth has been exposed, and therefore there is a need to crown it. Sometimes there's enough tooth there to actually put a composite filling on the top, which which is fine. But I think the thing is with it, everybody, I mean, I'm not a dentist either, but is that each one is slightly different, and what works for one patient won't necessarily be the case for another.
Yeah, thank you. No, that's really good. And like you say, it is difficult for the dentist on the current contract, given what they're paid. And I do sympathise to a level to my dentist that's kind of refused it, and that's why I'm not naming any names here today which dentist it is. But at the same time, I think this does need to kind of be enforced better, because they are taking the mickey a little bit by picking and choosing.
I mean, that's why in the end we just thought, well, we're going to go for broke here and come up with our own service delivery for root canal treatment, because unfortunately patients are the ones caught right in the middle of this.
Right. Thank you. Thank you, Martin. Thank you, Jeremy. And Jeremy, we have a couple of questions came through the chat. So one of them is, have the hospital started accepting dental referrals? I think you responded to that already.
Yes.
And
yes,
then,
they have.
Do you have any statistics to show how many patients were seen for endodontic treatment by the secondary care providers for endodontic in comparison to the number of referrals they received?
I don't. We could look at that. I don't have it to hand. They do hold data on terms of what they would call the number of rejected referrals. So I will certainly look into that, and if I have that available to us, I can quite happily share it with you.
Very good, great. Thank you. Any other questions for Jeremy? Debbie, where would you can unmute yourself.
Yeah, it's just a quick one. On that subject, dentists who don't want to do or can't do root canal treatment because they're not experienced enough, do they have to refer to a hospital, or can they refer to this secondary?
No, they refer into the hospital, and the reason for that is that you're referring into a consultant who will then look at that referral and sort of determine what level it's at, because there are some occasions where it goes in and actually they'll say, oh, this is very complex and we need to do it. But on the other side of it, they might look at it and say, this is pretty straightforward. And the difficulty previously was they would have just sent it back to the dentist, and then the patients then go around in circles because the dentist is saying, well, I'm not doing it. And then the patient, so by then sending on what they call, this is a level 2, we're sending it on to a community intermediate provider, they'll do it.
And is there I was going to say, is there a sort of standard length of time from, referral, not necessarily a referral to the hospital, but from the hospital then referring to the intermediate?
Yeah, I mean, I think generally, they're not. I mean, what we try and do is, even though it's intermediate level provider, we try and work within the 18-week pathway anyway. So generally, if patients are referred in, we're certainly within the community. Once the consultants triage that referral and if they send it on to the relevant provider, those patients are seen very quickly. There's not a long wait, and you're talking about weeks, no more than that. Whereas again, one of the issues previously when we didn't have this, the waits potentially in hospital were severe, and that's one of the reasons why they've increased their threshold and said, look, we just cannot take these because they were the majority of the referrals. But obviously, as I said before, root canal treatment takes a long time anyway. So it doesn't really matter in terms of whatever processes you put in place. You can only see so many patients in a session, and so therefore, as I said, there's not a long wait, and patients, and obviously that's the key, because patients generally who need root canal treatment are in pain.
Okay, thank you.
Right, thank you very much, Jeremy. Any other questions from anyone else? Or I can quickly ask another question. That's not about the treatment only, but I've heard from some of our members who are a bit confused, and I guess it's not only them. We know that dental services and GP services are both primary care, but their settings are quite different. So I think a bit more clarity on the NHS contract with dental practices will be really useful. If that makes sense.
I mean, I think, they are very different because the structure of the contract is very different, and also with GPs, their contract is far more all-encompassing, because obviously the numbers of services that are delivered by GPs to patients is very wide-ranging, and whereas with dentistry, it's always been a different model of this mix of private and NHS. So the NHS contract, which is the same one that was introduced in 2006, it sort of is simplistic in as much as there's only 3 bands of treatment, and whichever band of treatment you fall into, that's the price you pay. So there's only 3 potential costs associated with NHS treatment, and 4 if you count the urgent stuff. So, and again, it's about, band 1 being your bog standard routine checkup, scale and polish, and then band 2, which is where the majority of work goes on, is primarily fillings, root canal treatment, and anything that was. And then obviously band 3, which obviously is the most expensive, is things like dentures, bridge work, crowns, and that type of thing, because obviously they're the more expensive items. But again, I suppose the comparison is, if you have a crown done on the NHS, you'll pay the band 3 charge, which is around 260, excuse me if I get that right, 270 pounds. Whereas if you were paying for that privately, as Martin will attest, you could be paying 2, twice, 3 times that privately. So that gives you an idea of why it's such an issue, because actually the costs associated with delivering root canal treatment, actually once you've taken up the lab bill associated with the manufacture of the crown on the NHS, in some cases, some practices probably don't even break even.
Right. And in terms of how many NHS patients they can have registered on their list, does that differ from practice to practice?
It does. And I mean, again, because people, and there's no reason why they should think any differently, but because physically that was the big change in 2006 when the new that contract came in, registration effectively ceased. So the responsibility was only for ever a course of treatment after that. So, you're not obliged to go back ever again as a patient, but also they're not obliged to see you again. But obviously it's in their interest to have a list of patients, because that's how they achieve their contract. So, and the key thing is that they need to make sure they've got a list that's means that that they can deliver to that group of patients, rather than having too many on there, which means that they invariably can't. They have a contract currency or a contract activity requirement. And as you probably know that if they don't deliver on that contract, if they deliver less than 96% of their contract, the residual money gets clawed back by the NHS at the end of each contracting year. So that's where it's very different to GPs. GPs have effectively a contract which is a block contract for the delivery of X number of services. If general dental practitioners don't achieve their contract, they lose the money.
Right.
So the money comes back to the NHS. So that's quite different. That's a very different type of contract to, say, those that exist with either GPs, pharmacists, or even optometrists.
Right. And very last thing, Jeremy, I know we have to finish soon. You said that on 5th of October, the practices should start providing full range of services. So will that be announced somewhere? Or?
Yeah, I mean, what I would say is that the vast majority are already doing it. So the 5th of October was the absolute deadline by which practices had to be stood up. So they're already. So it's not like everyone's already. It's not going to be like a big bang on Monday where everyone says, right, all dentists are open.
Oh, I see.
So the majority of them are already open. Because from the 8th of June, all practices were in a position where if they had all of the relevant things in place, could open. So since the 8th of June, it's been a build-up practice. Yeah, so it's
right.
The 5th of October is just the absolute deadline that we put on it for practices to be up and running.
Perfect, thank you. And I think
can I ask quickly, will St Leonard's be open then?
St Leonard's is open anyway. St Leonard's is open as a CD, the community dental services. I think the thing is, St Leonard's is not a routine dental provider. St Leonard's is a specialist community special care and paediatric provider. They're not a routine. They're not a high street dental practice.
All right, so they're actually functioning, because my information that I've received is that patients are still being waiting.
Oh, there will be a wait because they've got a backlog. Because
I know that they've got a back. Okay, but I just want you to know, because we've been informed that they're actually not opened as yet.
No, they are. They are open.
Okay.
Yeah, I've spoke to someone from St Leonard's as well, and they are open, but not for new appointments, for existing patients as well. Yeah. Malcolm, with you.
Just a clarification. Can the 111 service refer for secondary care to any of the dental hospitals in London?
Yeah.
Because when I visited 111 last year, they couldn't refer directly to Guy's.
No, they can't. No, they won't. They would only refer onto a hospital if it was an emergency situation.
Yeah.
But if anything less than that, it would be about. So referrals have to come from either a GDP or a doctor or something like that into secondary care. But 111, unless it was a blue light scenario, wouldn't refer you to a hospital. They don't have that facility, and they don't have that capacity to do that.
Told me they could refer to other hospitals, but not to Guy's.
It depends on what services are available. It just depends. I don't think that's strict. I mean, 111. I mean, it depends. I know it sounds daft. Depends on which time of the day you ring through. Because in the evening, obviously, generally we have the dental nurse triage service that's available, so patients would be put through to them. During the day, obviously, you're just talking to a normal 111 call handler, but they don't. 111 obviously a call handle, but they don't make direct referrals to hospitals. If they felt that obviously they were being told was an emergency, they would actually instigate an ambulance going to pick a patient up, on the basis of what they were being told. But beyond that, if a patient needs what you would call routine hospital referral, that would come from the GP or the dentist.
That's it.
Right.
Okay,
Excellent.
thank you.
Thank you very much. It's 2 o'clock now. I mean, if anyone wants to